in an upcoming edition of the Parkinson's Messenger that comes out. And so that certainly would be one way that we could answer some additional questions, especially if they're of general interest for everybody. And so I hope that my presentation style does not put everybody to sleep this evening. So sometimes PowerPoint slides and PowerPoint presentations can be exceedingly boring, and I hope that that does not put everybody to sleep as we move ahead. Maybe Mary Sue will record this lecture if it does, and you guys can listen to it, and that might be one cure for your sleep issues.
I am recording it. Folks, I am recording it, okay?
Okay. So let's talk initially about not abnormal sleep, but let's start by what is normal sleep. You know, we all think about, you know, average amount of sleep or our target amount of sleep as being about 8 hours. Anywhere from 7 to 9 is really considered very normal and average. When we get to routinely sleeping less than 7 hours regularly, we may end up having some issues. When we talk about something called sleep latency, that's the amount of time it takes you to actually fall asleep when your head is finally placed onto the pillow. So most of us, ideally, it would take 10 minutes or less to fall asleep. If it is routinely taking you longer than 10 minutes, that can be an issue, and that's something that we'll talk about as a primary insomnia a little bit later. We're going to talk a little bit about what normal sleep structure looks like, and you know, these confusing topics of what is stage 1 sleep, what is stage 2 sleep, what are stages 3 and 4, and what the heck is REM. It's not just a band from the 80s. It stands for rapid eye movement sleep, and that's when we dream. And sometimes for patients with Parkinson's disease, that can be a bit of an issue. For napping, we accept napping in our culture only in the very young and in the very elderly. For people in their middle ages, or what is considered the productive age cycles, napping is often frowned upon and not something that is acceptable behavior. So we can certainly talk about that. So what are things that might influence how sleepy you are in any given 24-hour time frame? Well, these might seem a little bit intuitive, and I hope they do. So the sleep-wake cycle, or what we call process S, that's how much time it's actually been since you last slept. So bottom line, if you've been awake for a long period of time, the sleepier you're going to become, or the sleepier you are. And the shorter amount of time it is, the less sleepy that you're going to be. And so if you've taken a very long nap in the middle of the afternoon and you've awakened at 4:30 in the afternoon, and then it's 10 o'clock and you're trying to go to sleep, and you're in bed wondering why you can't get to sleep, well, that 6-hour duration may not be quite enough time versus if you had been up for most of the day. In addition to that, we recognize that the circadian rhythm of our brain plays a big role, and that's what's called our biologic clock. And that is influenced by light and darkness. And when it becomes very bright out, we tend to wake up. When it gets dark out, and it's getting darker earlier and earlier these days, we become a little bit sleepier, and that's because there's a surge of melatonin within our brain that tells us it's time to actually get ready and go to bed. So these two factors work together, and they are things that we can't ignore as we are looking at how we can get good sleep. Let's talk briefly about sleep architecture. So if you look at this relatively confusing looking diagram over here, it really is broken down into just a simple block diagram of the different stages of sleep. And so we have non-REM sleep and we have REM stage sleep. Non-REM sleep is when we are not dreaming. And that's broken down into typically 4 stages, what we call stage 1. And for most of us that we are in stage 1 sleep for a relatively short period of time. And stage 1 sleep is when we begin to doze off. People looking at us know that we're dozing, but if we are awakened during that time, we can have some plausible deniability. We can say, oh, no, I wasn't really asleep. I was just resting with my eyes closed. And so stage 1, very easily awaken, and tends to be a very shorter period of time when we are first dropping off. Stage 2, we're a little bit more deeply asleep. If we were to look at a brainwave recording at stage 2, we begin to start seeing some slowing of the electrical activity of our brain when we're in stage 2 sleep. And that tends to last for a little bit longer. If somebody awakens us during stage 2 sleep, we definitely know that we were sleeping, and it takes a little bit more effort to wake us up during those time frames. Stage 3 and 4 are the more restorative stages of sleep, what we call slow wave sleep. And hopefully we're in that deeper stage of sleep for a longer period of time. And then we begin to cycle into what we call our REM sleep behavior disturbance, or not disturbance, but REM sleep time. And so when we are in REM stage sleep, we're actually in a little bit of a lighter stage of a sleep. We can be awakened, which is very often why we feel so fuzzy and kind of half remembering our dreams when somebody awakens us during REM sleep. But this cycle going through stage 1 to 2 to 3 to 4, and then up into REM, and then back down into stage 4, and then back up into REM, and then back down into stage 4. It is very common and normal for us to cycle through those stages 4 and 5 and 6 times every night, with in the later stages of the evening or the later stages of the night as we're sleeping and early into the morning, the REM sleep becomes longer and longer. Now, this is normal sleep architecture. And so each one of these cycles tends to range from anywhere from 60 to 90 minutes on average. Some individuals are a little bit different. But when we talk about REM sleep, when we talk about non-REM sleep, these are the things that we're talking about. What might impact our ability to get to sleep? Actually, there's a whole number of different factors, not just Parkinson's disease, but a whole number of other factors that can impact our ability to get a good night's sleep. And so here in the middle, we see, our ideal good night's sleep. So different things like sleep hygiene. If we're watching television in bed, that can impact our ability to get to sleep. Health issues, whether that is obstructive sleep apnea or Parkinson's disease or breathing disorders because of COPD or anything else, that can impact our ability to get a good night's sleep. Depression and other mood issues can impact our ability to get to sleep. Being angry at somebody for whatever reason and having a difficult time controlling that anger can make it very difficult to get to sleep at night. On the left-hand side of the screen, so what would be pretty much 10 or 11 a.m. or 10 or 11 o'clock, we see this alphabet soup, RLS, PLM. That stands for Restless Leg Syndrome or periodic limb movements. Restless leg syndrome is very commonly associated with people with Parkinson's disease. Restless leg syndrome is a tactile sensation in our legs, or an unusual feeling within our legs that occur when we try to rest or get to sleep. It's kind of a funny, bubbly, uncomfortable sensation that goes away when we move our legs and feet. Periodic limb movements are very often associated with restless leg syndrome, but can be sometimes seen just on their own. And periodic limb movements are an involuntary jerking of our legs that can disrupt our ability to get a good night's sleep, and it can absolutely disrupt our partner's ability to get a good night's sleep if they are occurring frequently. Sometimes poor time management can be an issue with sleep. We just don't leave ourselves enough time to get to sleep on time, and then we have to get up early the next day, and so we may not be sleeping as long as we need to. People that have problems with memory loss can sometimes have issues with good sleep, and some of that has to do with sometimes becoming a little bit confused or disoriented at night, and sometimes the cognitive dysfunction can really play havoc with our ability to get a good night's sleep. And then we can have just out and out primary insomnia, which can lead to some sleep issues. What about Parkinson's disease and sleep problems? So we know that this is very frequently identified, and in much of the literature, we know that as many as 90% of patients with Parkinson's disease have some kind of an associated sleep disturbance. And so whether that is problems with insomnia or problems with vivid dreams or getting up to use the bathroom or those periodic limb movements, or maybe it's daytime sedation, all of those factors can contribute to problems with getting a good night's sleep. For patients with Parkinson's disease, even if they've never had issues with dream enactment or other problems, more than a third may develop issues with nightmares, vivid dreams, or even what we call night terrors, which is something that's often seen with young children, waking up very frightened for no apparent reason. Patients can talk in their sleep. They can shout out in their sleep. Even individuals who have difficulty projecting their voice during the day while they're awake may be surprisingly loud while they're sleeping and talking during their sleep. As we've already mentioned, there's a very common risk of restless leg syndrome and periodic limb movement disorders in patients with Parkinson's disease. And then we also have to worry about obstructive sleep apnea, which can be seen in people with Parkinson's disease. Parkinson's disease doesn't protect us from developing obstructive sleep apnea. I had already touched upon the circadian rhythm and Parkinson's disease. We know, so let's think back to those sleep cycles and those normal sleep stages that I talked about. We've identified that patients with Parkinson's disease may have a longer sleep latency, and they may have an increase in stage 1 sleep, which means that that lighter stage sleep where we don't really feel we're sleeping may take up a longer or a larger amount of our sleep cycle during the evening. Reduced sleep efficiency just means that when we're in bed, we're not sleeping quite as frequently, and then rapid eye movement behavior is very frequently identified in patients with Parkinson's disease. The circadian rhythm is, again, that biologic clock associated within our brain, and this is what helps us get sleepy in the evening and helps us be awake during the day. Now, what impacts the circadian rhythm? Well, if we don't make enough melatonin, and sometimes individuals with Parkinson's disease don't quite make enough melatonin. Melatonin is a hormone that is normally produced by our brain. There's a tiny little gland called the pineal gland that on certain images looks almost like a little tail in the very back part of our brain. That's where melatonin is produced, and it normally surges up in the evening hours, typically between 8 and 9 p.m. as it's starting to get dark out, and then it drops down earlier in the day. Now, the more melatonin we have in our brain, the sleepier we are, and the easier it is for us to get to sleep. And the less melatonin we have, the more awake we are. Now, daytime or more modern issues can impact our circadian rhythm when we're exposed to bright lights, artificial light, when we're exposed to the light from a television, when we're exposed to the light from something like a cellular phone. That can absolutely make a difference in terms of the amount of melatonin that we're creating. And so when we talk about sleep hygiene, we're going to touch back upon why avoiding a certain amount of screen time, especially later in the evening, can make a bit of a difference. Along that circadian rhythm, with those factors being a little bit off, excessive daytime sleepiness is seen in almost half of individuals with people with of patients with Parkinson's disease. And so that means that even if they're sleeping fairly well during the day, they may be pretty sleepy, or even if they're sleeping well during the night, they may be fairly sleepy during the day. How do we impact that? Well, sometimes we actually need to use certain stimulants. Sometimes just a good strong cup of coffee can be very beneficial. Coca-Cola, if you so desire that, or other caffeinated beverage can be very beneficial, but we want to make sure that we're not drinking that too late in the afternoon, because unlike caffeine can actually impact us many, many hours after we consume it. So it can be very helpful early in the day to keep us awake through the day. But if we drink coffee a little bit too late in the afternoon or in the evening, can absolutely make a difference regarding how well we sleep through the night. Sleep attacks or sudden onset of sleep have been reported in patients with Parkinson's disease. They've been very commonly reported in patients that are on certain medications. And hopefully, if you have been placed on a dopamine agonist, you've been warned about the possibility of sleep attacks. It is common enough that if you are a commercial airline pilot and placed on a dopamine agonist, you're no longer flying because of that risk of a sudden sleep attack. In Europe, patients that are placed on dopamine agonists are no longer allowed to drive because of the risk of sleep attacks. So that is something that you should absolutely be aware of. So sleep fragmentation or disrupted sleep is absolutely something that patients with Parkinson's disease can experience. And we're going to touch more upon that in a little bit. And, is it because of the neurodegeneration? Is it because of those loss of those cells within the substantia nigra system that is impacting our difficulties with the circadian rhythm? That's something that we're actually wondering about and questioning. There was actually a recent study that was published looking at the importance of circadian rhythm changes in patients that, in fact, hadn't yet been identified as having Parkinson's disease, but were followed for several years, and it was identified that individuals at a younger age that developed circadian rhythm disturbance were in fact more at risk of developing Parkinson's disease down the road. And so much like issues like constipation, reduced sense of smell very early on, maybe that's going to be one of our clues to try to help identify Parkinson's disease earlier. So other issues that we see with Parkinson's disease and sleep problems can include just primary insomnia, or just out and out insomnia, or an inability to sleep. We've already mentioned the daytime sleepiness, and then disruptions during sleep. And so let's talk more about each of those. So Parkinson's disease and insomnia. So there can be many, many different factors that lead to difficulty sleeping, even when we have Parkinson's disease. So primary insomnia is something that was present before you developed Parkinson's disease. And so what does that mean? Well, if you come into the office and you say, I'm not sleeping very well, and my question is, when did this start? And your response is, well, I've always had difficulty sleeping. I've never been a good sleeper. Nobody in my family sleeps well. You probably have primary insomnia. And that's something that we're going to have to work on, and that may be a different approach than something that is thought to be caused specifically by Parkinson's disease. Insomnia that's caused by Parkinson's disease very often gets better if we can control your Parkinson's symptoms to some extent. Depression, as we had touched upon, can contribute to difficulty with sleep, and that can be seen both before Parkinson's disease, or it can be seen after Parkinson's disease develops. Now, we know that depression is very commonly a non-motor symptom associated with Parkinson's disease. Depression is not a lack of will. Depression is not some kind of a self-weakness, but it is specifically a neurotransmitter disorder that can be associated specifically with the same neurotransmitter imbalances that are causing your motor symptoms. Sometimes we wake up frequently because we have to go to the bathroom, and sometimes medications can impact our ability to sleep well. So what are the causes if we think that insomnia is specifically due to our Parkinson's disease? How are we going to make that diagnosis? Well, sometimes it's related to the fact that we took our last dose of medication a little bit too early, and it's really hard to get into bed, and it's really hard to get comfortable once we're in bed, or maybe once we're in bed, we're shaking so much we can't get to sleep, and the shaking is bothersome. I've had patients tell me that it's the sound of their tremor against their pillow or their sheets that's loud and annoying. It's not necessarily the tremor itself that's bothersome, but the sound that the tremor is making against their night clothes or the bed covers that is bothersome. We know that medications for Parkinson's disease are woefully short-lived, and that's something that we fight with throughout the course of the day, and it's something that we fight with through the night. None of the medications that we have really are ideal at lasting all night long, and so if medications wear off, that can lead to some symptoms that cause us to awaken. Or as I already touched upon, maybe we're just not taking enough medication through the night or before we go to bed. So there's 3 different factors that we look at if we're going to attribute difficulty sleeping or insomnia to your Parkinson's disease. The first one is, do you have a hard time actually falling asleep? And that might be because of the issues with tremor, as I touched upon. That may be because of just your last dose of medication was too many hours prior to trying to go to bed. Or there may be a different factor. Maybe you took a nap a little bit too late in the afternoon and you're just not ready to go to sleep yet. But that's always something that we want to look at. So as you are thinking about, I have really a difficult time sleeping, maybe you can ask yourself these questions. Is this, is my difficulty sleeping because I just can't get to sleep at night, and then finally after a period of time I'm able to fall asleep and I sleep for the rest of the evening? Or maybe you have what we call stage 2 insomnia, where you wake up after you've been asleep for a few hours. You're able to get to sleep right away without any difficulty whatsoever. You drop off very rapidly, but then you wake up after a few hours for some reason. Maybe you have to go to the bathroom. Maybe your medications have worn off. Maybe there's a noise outside. Maybe some other factor. But whatever it is, you're waking up after only a few hours, and then it's hard to get back to sleep. And then if that's the case, we want to know, why is it difficult for you to get back to sleep? Is it because your Parkinson's symptoms don't allow you to get comfortable? Is there something else going on? And then finally, stage 3 problems, or stage 3 insomnia due to Parkinson's disease. You've slept for most of the night, but you're waking up later in the night, very early in the morning. It's far earlier than you really want to get up, but it's very, very difficult to get back to sleep. And you know that if you in fact get out of bed at that very early time frame, that it's going to be you're going to have just a rough time through the course of the day. So again, as you approach your physician to talk about the fact that you have sleep issues, knowing where your sleep problems are could be very, very helpful. So depression and anxiety can absolutely lead to issues with sleep. We know that people with anxiety have a very difficult time going to sleep because it's hard to let go of some of their worries and concerns. Maybe this is when my Parkinson's disease is going to get worse. What's going to happen to me down the road? Or maybe my medication isn't going to keep working as time goes on. Depression is very often associated with sleep issues, and that can be associated with falling asleep, that can be associated with staying asleep, and it can be associated with waking up early. So those 3 stages that I've already mentioned may all have a root if you have a primary depressive issue related to your Parkinson's disease or prior to your Parkinson's disease. We know that there are many different medications that can be very helpful to treat both anxiety and depression. There's not a one-size-fits-all for medications, and so this is something that, again, you're going to want to work with your doctor to determine which one is going to be best for you. Unfortunately, there are always side effects associated with medications, and things that we have to think about are that if we're using medications to treat anxiety, sometimes that can lead to sleepiness the next day. If we're using medication to treat depression, sometimes that can be associated with too much wakefulness or insomnia during the day. And some of the common ones that are used, fluoxetine or Prozac, citalopram or Celexa, sertraline or Zoloft, and paroxetine or Paxil, all have been associated actually both with too much wakefulness and difficulty getting to sleep, and correspondingly or conversely, some sleepiness during the course of the day. And so everybody has potentially a different reaction to some of these medications, but certainly these have been associated with some insomnia. If you are taking this in the evening and you're having a hard time getting to sleep, that might be just an easy fix to start taking it earlier in the day. But again, talk to your specific doctor about that if you're going to make a change. Selegiline doesn't seem to be used quite as often as we used to use it. It is a medication in the same class as Azilect or Rasagiline. It is a monoamine oxidase inhibitor. We know that Selegiline is metabolized as it's beginning to be absorbed through your stomach. It's metabolized into an amphetamine-like substance. And so it very frequently can lead to wakefulness for many individuals. Now, this medication should be taken early in the morning and then no later than noon or 1 o'clock because of that amphetamine-like substrate that is metabolized. And if you are on Selegiline and you're taking it in the evening and you're having a difficult time with sleeping, that certainly might be one of the first things that we look at. And then conversely, sometimes we use that metabolite to our advantage for people that have daytime sleepiness. Selegiline can be used to help improve duration of action of carbidopa levodopa and may also help with some wakefulness for individuals. Now, just because you've got Parkinson's disease, you may have other underlying medical issues, especially lung conditions, and many medications that are used to treat chronic obstructive pulmonary disease can contribute to wakefulness as almost like a caffeine-like side effect to them. As I already touched upon, coffee can contribute to wakefulness, especially if we drink it too late in the day. Alcohol, some people feel that they can't get to sleep unless they have a glass of wine or a couple of beers or a highball or some other alcoholic beverage. We know that alcohol can lead to some early sleepiness, but it disrupts those stages that we had already touched upon. And people who rely on alcohol to get to sleep very frequently don't get as much of the slow wave sleep, as much of the stage 3 and stage 4 sleep stages, and alcohol can disrupt REM sleep cycles as well. And so people who rely on alcohol very often feel as though they're not quite as rested, and that's because they're spending more of their time in those lighter stages of sleep. Many people like to smoke cigarettes, and the nicotine in cigarettes can be a very potent stimulant. And if you're smoking right before bed, that might be waking you up enough so that it's hard to get to sleep. Just a little cartoon, how many people feel that it's very easy to doze off. You know, if they're trying to get something done, very easy to doze off in front of the television screen watching something. Even while driving, they feel very, very sleepy, but then laying in bed, doing wide awake, hard to get to sleep. So I'm sure that many of you feel as though this is something that you experienced. I know I have. So primary insomnia that has occurred prior to Parkinson's disease. What the heck is insomnia when we talk about it? Really, it's just an inability to be able to go to sleep. It's an inability to stay asleep as we want to stay asleep as long as we want to, and it's associated with waking up far earlier than we really want to. Now, we break down insomnia into what we call acute and chronic. Acute insomnia very often will, by definition, last for less than a month, and it might be associated with a severe illness. It might be associated with a stressful event. And what we have identified is that the common medications that we use for insomnia work really, really well in the acute stages. Chronic insomnia is insomnia that has lasted for more than a month and may be ongoing for a long time. How do we treat chronic insomnia? Now, this is what many people don't like to hear. Very often, there are some underlying factors that make it difficult for us to fall asleep at night. And we have to figure out what those factors are. And we have learned that therapy and what we call cognitive behavioral therapy, or we're learning various tools to help recognize what is impeding our ability to fall asleep, are often far more effective than medication. But those are difficult, and primary insomnia is very frequently not easy to treat, and we recognize it is far easier to reach for a medication. Now, this is how transient insomnia or acute insomnia becomes chronic or progressive. So we see that transient insomnia occurring during an episode of stress. And for some of you, this episode of stress may have occurred many, many years ago, decades ago. We get really, really frustrated waiting for our ability to fall asleep. Our inability to fall asleep disrupts our night, and then we begin to worry about how we're functioning during the day. And then we don't sleep, we're more stressed, we're frustrated, we don't get sleep, we begin to worry, and that cycle goes on, and that becomes very chronic, even after whatever that original cycle had been has resolved. But our inability to get to sleep and remain asleep continues. And that's where cognitive behavioral therapy can help us, because it can help us recognize what our frustration is. It can help us develop some tools to eliminate that delayed sleep and help us recognize the worry about our ability to function during the day and what we might need to do to make that better. So when we talk about treatment of chronic insomnia, in addition to cognitive behavioral therapy, we talk about things like sleep hygiene. So what the heck is sleep hygiene? That doesn't mean taking a bed bath. That doesn't mean taking a shower right before you go to bed. It means developing good habits prior to going to bed so that you are able to get to sleep when you want to. It is so that your brain begins to associate going to bed with being relaxed and being able to go to sleep. If you have ever taken care of an infant who is firstborn, very often days and nights for infants are topsy-turvy, and babies stay up all night long crying and being awake, and then they sleep all day long. And so we have to help infants begin to change their circadian rhythm and recognize when it's time to go to sleep and when it's time to be awake. And we do that with various habits and rituals that we become. And so things like a bottle and a bath and a snuggle and a story or a song all help infants and young children recognize when it's time to begin to wind down. And we can do that same thing for ourselves to help begin to wind down through the evening. We can begin to avoid coffee. We can avoid, excess alcoholic beverages. We can make sure that our bedrooms are quiet. We can make sure that we're not eating too heavily before we go to bed. Keeping regular sleep hours are very important. If we have erratic sleep hours, then it's very difficult to try to get to sleep on a regular basis. And that's part of developing a good sleep hygiene program, is getting into a more normalized or regular sleep-wake cycle. So going to bed at a certain time and waking up at a certain time on a regular basis. We know that daily exercise can be extremely beneficial to help us sleep at night, but we need to be cautious about when we're exercising. If we exercise a little bit too close to when we want to go to bed, then our body's all geared up and ready to go, and it's very hard to then wind down and fall asleep. So we want to make sure that we're not exercising too soon in terms of when we're going to bed. We've talked about avoiding napping. Study after study has identified that if we nap for more than about 20 or 30 minutes at a time, that absolutely can impact our ability to fall asleep at night. And I'm already hearing the arguments that if I don't nap, then I'm too exhausted to do anything, and I can't get to sleep in the evening anyway, so I have to nap through the course of the day. So these are all things that therapy and cognitive behavioral therapy can help you with. So other things that we look at: going to bed only when we're ready to go to sleep. We want to make sure that when we're in bed, we're sleeping about 90% of the time. If we've been awake for more than 20 or 25 minutes, it's time to get up and go someplace else and do something else so that we can then come back to bed when we get tired again. We want to make sure that what is happening within our bedroom is simple. It's not too busy. We're not worried about falling. We're not worried about knocking something over. And the other thing that we want to keep in mind is proper perspective. And that means that if you are sleeping well 75% of the time, approximately, you're really considered to have your sleep under pretty good control. And sometimes that's hard to recognize or hard to understand. Are we really sleeping well enough? And so that's where sometimes keeping a good sleep diary can be very beneficial. We all have very, very short memories. And when we come to see our physician, we tend to focus on what we most recently experienced. And so if the 2 nights prior to seeing our doctor, we slept really well, our comments are, yeah, we've been doing well. I'm sleeping great, not having any difficulty whatsoever. Correspondingly, if those 2 nights were not good sleep, then we tend to say, oh, I'm not sleeping at all. I'm not sleeping whatsoever. But again, keeping a bit of a diary regarding what's happening regarding your sleep-wake cycle can be extremely beneficial as you go to talk about it. So medication, many people want to just have a medication that's going to put them to sleep. And more we're recognizing that sometimes that's not always the ideal option. Now, certainly some medications we are going to continue to be able to use. We need to be aware that there are some new dosing guidelines for Ambien, which the FDA has now really restricted. And so for females, the maximum nightly dose of Ambien has now dropped from 10 milligrams to 5 milligrams. And so those are the new recommended dosing guidelines. Benzodiazepines, things like Xanax or Ativan, Klonopin, generic names alprazolam, luraprezolam, or lorazepam, clonazepam. So there are new what we call black box warnings, which means that when we go to prescribe these medications, we're reminded that for people over the age of 65, that risk of falling, risk of confusion, risk of memory problems are all very, very high. And there are restrictions in terms of the amount of these medications we can now use on a regular basis. So if your doctors are starting to talk about trying some other things to help you get to sleep, some of it has to do with some general guidelines that are coming from other factors, not just your doctor's personal opinion. So other causes of daytime sleepiness. So we've already touched upon the insomnia because of Parkinson's disease. Medications, as I mentioned, can lead to daytime sleepiness. Sleep apnea can lead to daytime sleepiness. And then restless leg syndrome and periodic limb movements can contribute to daytime sleepiness by disrupting our sleep. Now, we've recognized that periodic leg movements can be almost as disruptive to getting and attaining slow wave sleep as sleep apnea can be. And so those are things that we need to try to make sure that we're identifying and addressing. What are some of the medications that can lead to daytime sleepiness? We've already touched upon the anti-anxiety medications. Pain medications very commonly can be associated with daytime sleepiness. Muscle relaxants that are sometimes used to help relax our tight muscles can be very frequently associated with daytime sleepiness. Anti-seizure medications can be associated with daytime sleepiness, and not just phenytoin or Dilantin, but levetiracetam, also known as Keppra, topiramate or Topamax. All of those can be associated with daytime sleepiness as well. Gabapentin is very commonly used to help control chronic pain conditions, whether that is associated with pain from shingles or neuropathy from spinal stenosis or diabetes, but that can lead to daytime sleepiness as well. And what if somebody with Parkinson's disease has been having issues with hallucinations or sundowning? Sometimes medications that we use to try to control those outbursts, quetiapine, olanzapine, risperidone, can contribute substantially to daytime sleepiness. Maybe what you have isn't sleepiness during the day. Maybe it's something that we call pseudo-sleepiness. And that's related to low blood pressure. And I hope that everybody that's listening has had their blood pressure assessed both sitting and standing or lying and standing as they are at their physician's office to look for evidence of a drop in blood pressure, because we know that patients with Parkinson's disease are very apt to develop issues with a drop in blood pressure on standing. And all of the medications that we use to treat Parkinson's disease can make that drop in blood pressure on standing much worse. And sometimes patients don't recognize a sense of dizziness or wooziness when they stand up. Maybe it's just that they feel exhausted if they try to do anything, especially if they've been standing for a period of time. I very frequently hear, oh, I can't even do the dishes after I've been standing at the sink for 2 or 3 minutes. I get so tired, I have to just sit down. And then we check blood pressures and we see a very substantial drop in blood pressure. And if we can control that, very often patients begin to feel a whole lot better and are a lot more awake and alert during the course of the day. So if you have issues with daytime sleepiness, make sure that this is one thing that you are not overlooking and that your blood pressure is being monitored. So we've touched upon restless leg syndrome, very frequently seen with patients with Parkinson's disease. Again, it is a leg discomfort. It is not a movement of your leg. It is a sensation in your legs. Worse as you are attempting to rest and relax, very frequently worse in the evening, but some patients find that if they just sit down to try to go to a meeting, if they try to go to a religious service, if they try to go to an afternoon symphony or matinee, obviously in this stage of COVID pandemic and shelter at home, those are much less likely to occur. But even just sitting down and attempting to watch television during the afternoon may be disrupted by a sense of discomfort that then improves when somebody gets up and moves around. So restless leg syndrome can be seen with as many as 10% of the population. Obviously, 10% of the population doesn't have Parkinson's disease, but patients with Parkinson's disease seem to be more at risk of restless leg syndrome. Sometimes restless leg syndrome can be begin as early as when somebody is a child, and it can sometimes be associated with anemia, especially if that anemia is related to a deficiency in iron. It can be related to certain medications. Those antidepressant medications can often exacerbate or worsen symptoms of restless leg. Sometimes allergy medicines can worsen symptoms of restless leg. And we've talked about the periodic limb movement disorder can be associated with restless leg syndrome. What we have to keep in mind is that both PLM, periodic limb movement, and restless leg syndrome are treatable, often with the same medications that we use to treat Parkinson's disease. So this is just a little cartoon, a man saying, "The doctor found out why I snore so loudly, obstructive sleep apnea." And his wife says, "So in English, that's inner neck fat." And the guy says, "I prefer the way he put it." So let's talk briefly about obstructive sleep apnea. It is actually more common than I think people realize. And many people with sleep apnea may be heavy, but several people are not. They appear to be of normal weight. As we are older, our risks of sleep apnea increase, much like many other factors, stroke, heart disease. If you are a man, your risk of sleep apnea is greater as well. Sometimes if you've got large tonsils or adenoids, especially in kids, the risk of sleep apnea is much, much higher. If you have a small jaw or a larger neck, your risk of sleep apnea is greater. Things like sedatives or medications to put you to sleep, alcohol, allergies, and smoking can all increase your risk of sleep apnea. Why do we make a big deal about sleep apnea? Because it's not just the fact that during the night people snore, they stop breathing, they may have some very loud gasping type noises, but during the day we know that sleep apnea can lead to significant sleepiness. It can cause mood disorders. For men, it can lead to erectile dysfunction, and it is one of the more common causes of reversible memory loss. And so we always want to look for sleep apnea, especially for people who are complaining of daytime sleepiness and some issues with memory problems. We know that untreated sleep apnea can lead to an increased risk of accidents, whether that is an accident at home, whether that's an industrial accident at work, or whether that's a motor vehicle accident. So we always want to be aware of that. And even most concerningly, people who have sleep apnea that is not treated run a risk of developing elevated blood pressure congestive heart failure, even having heart attack or stroke, developing irregular heart rhythms like atrial fibrillation, increased risk of weight gain, and then diabetes. And people who have untreated sleep apnea are at higher risk of dying unexpectedly. So if your doctor has told you that you have sleep apnea that needs to be treated, it's not just a diagnosis du jour, it is something that we recognize can be very important in terms of impacting the quality of your life. So how do we treat it? Well, if you are heavy, a little bit of weight loss can be helpful. Sometimes just an adjustment of sleep position. Instead of sleeping on your back, sleeping on your side, making sure your head is elevated. CPAP is a proven therapy. 70% of patients that are placed on a CPAP device actually do get used to it. There are many, many different masks available now for CPAP. And so if you've tried one and you didn't like it, there may be others that will be very helpful or beneficial for you. Surgery done less frequently, but in severe cases, something that still can be looked at. And then sometimes just a dental appliance to adjust your jaw can be helpful in terms of eliminating sleep apnea. So bottom line, sleep apnea, common, easily diagnosed and treated. So reduce your risk of significant disease. And if you don't care about yourself, think about your bed partner, because they'll get a better night's sleep. And let's think about what Anthony Burgess has said: laugh and the world laughs with you, snore or gasp and choke because you have sleep apnea, and you sleep alone. Briefly, we're going to go through REM sleep behavior disturbance. That's a condition where the person who is asleep acts out their dreams. People walk, talk, move about. Usually it's less than 1% of the population might be impacted by REM sleep behavior disorder. But if you have Parkinson's disease, up to 50% of people with Parkinson's disease are at risk of developing this sleep behavior disturbance where they act out their dreams. For people with Lewy body dementia or multiple system atrophy, it is 90% or more. So very significant. And so when your doctor is asking you about dreams, do you talk in your sleep? Do you walk in your sleep? Do you move about? We are wondering about specifically REM sleep behavior disturbance. We've recognized that although clonazepam can be very helpful, we know that in a certain population that's not necessarily the best medication because of the risk of falls, because of the risk of memory problems. Melatonin has been shown to be nearly as beneficial as clonazepam, but with much, much less of the risk. And so melatonin can be a very effective treatment option for this. So Parkinson's disease can lead to other disruptions during the night, whether that's vivid dreams and nightmares, with or without REM sleep behavior disturbance. Patients might have hallucinations or delusions at night. They might think that somebody's there. Sometimes that can be in association with some sundowning, which can lead to agitation and difficulty with behaviors that can be seen. Sleep apnea or even seizures can occur in some individuals, and that also can lead to some significant disruptions through the course of the evening. Disruptions can be can be problematic for families. People who aren't sleeping well very frequently get moved to an assisted living facility because families have to sleep and become exhausted. And if they're not able to get to sleep, or somebody is at risk of harming themselves because they are not sleeping, that can be something that can lead to issues with being moved to an assisted living facility. When we recommend a sleep study, it's because we're trying to identify, does somebody have REM sleep behavior disturbance? Is it sleep apnea that is leading to some of the unusual behaviors, or is something else going on? And once we know specifically what the cause is, then we can best treat it, whether that's going to be with medication, whether that's going to be with a soft light in the night so that somebody can reorient themselves if they awaken. Maybe there's going to be some other factors that we look at. Sometimes frequent urination can make a big difference. I don't know if everybody's screen is blocked. This little cartoon actually says, I have a lot of get up and go for somebody my age. I get up at night and go. I get up at night and go. I get up and go and go and go. Many people with Parkinson's disease have nocturia, which just means going to the bathroom frequently at night. Now, is it because of Parkinson's disease or is something else going on? It might be related to a bladder infection. It might be related to an enlarged prostate. There could be something else that's happening. We talk about getting enough fluid through the course of the day, but if you're getting all your fluid in late in the evening, that's going to be a source of having to get up through the course of the night. Alcohol and caffeine can both act as a diuretic, meaning you're going to lose fluid, and if you drink those later in the evening, you're going to have issues with going to the bathroom. So bottom line, let's talk briefly about good sleep hygiene basics. This is revisiting, if you've been listening to everything that I've been saying so far, we want regular times to go to bed and getting up. We want to make sure that our bedroom is a quiet, safe, relaxing place. We're going to stay in bed predominantly for sleep or for intimacy. We're going to avoid naps later in the day. We're going to avoid alcohol, caffeine, or other stimulants late in the evening. We're going to try to sleep about 7 to 8 hours every evening. We're going to get exercise early in the day. We're going to try to avoid heavy meals late in the evening. And we're going to try to avoid stressful situations when it comes to bedtime. And so for those of you who are caregivers that are watching this, we recognize that when a patient with Parkinson's disease doesn't sleep, the caregiver doesn't sleep. And that can be a dramatic stress within the life or within the home. And so that's always something that we have to look at as a way to try to figure out how do we improve sleep, not just for the patient with Parkinson's disease, but for a caregiver as well. And for every caregiver who feels guilty about being frustrated that they're not sleeping, we always remind them, take care of yourself first. And whether that's through mindfulness, relaxation, or even some time away, that can be very, very beneficial. So we're going to close with just this little saying, day is over, night has come. Today is gone, what's done is done. Embrace your dreams through the night. Tomorrow comes with a whole new light. So I appreciate everybody's attention, and I will be available for some questions if you have any.
Thank you, Dr. Taylor. That was wonderful. Really, really, I think we all learned quite a bit. There are a couple questions in the chat. Let's address those first, and then if you have a question, you can unmute yourself, but let's start with the first one. How about the use of these sleep tracking apps on a smart watch? Can they overcome the tracking problem?
I guess I'm not sure what you mean by can they overcome
I'm not sure either.
the tracking
Marsha?
problem. I do know that for some of the tracking devices like a Fitbit or something, sometimes underestimate the amount of sleep that you're actually getting. And so that might be something that you'd want to specifically look at. I tell my patients that bring their Fitbits in and say, oh, this tells me that I'm not sleeping at all through the night. Especially if we know that there might be a problem with some REM sleep behavior issues, keep in mind that a Fitbit is going to count that movement as activity and being awake, when in fact you might still be asleep. So we want to look at those very closely.
Okay. What are your feelings about using melatonin?
I think melatonin can be beneficial for many individuals, and as I've noted already, there have been studies that have been done that have identified that melatonin can actually be a very helpful first-line therapy for people who have REM sleep behavior disturbance. And we've recognized that sometimes we don't need big whopping doses for this to be beneficial. Now, the other factor to keep in mind regarding melatonin is that if you have been using a sleep medicine and you're used to being knocked out by that sleep medicine, melatonin is not going to act that way. But it can help improve the quality and the quantity of your sleep, but it's not going to be something that is going to knock you out immediately. And if you are looking for abilities to fall asleep very readily, that's where maybe some cognitive behavioral therapy could really be of benefit.
Okay. What do you recommend for painful restless legs besides Mirapax, which caused hallucinations?
So if somebody has painful restless leg and pramipexole or Mirapax wasn't beneficial, there are many other dopamine agonists that could be helpful, whether that is ropinirole or the patch rotigotine. If those aren't helpful or lead to the similar type of hallucinations, there are many other medications that may be beneficial, including a sustained release version of gabapentin or other medications. So there are many different factors or things that we can use to treat restless leg.
Okay. Can regular use of melatonin be harmful? And also, is the use of antihistamine okay? Probably Benadryl is what he probably means.
So for what we've identified, routine use of melatonin seems to be quite safe. You know, that's as of today. We'll have to wait and see if anything changes as time goes on. So we don't recommend regular use of antihistamines like Benadryl, and that includes things like Tylenol PM, Advil PM, to go to bed at night, because those medications can lead to what we call rebound insomnia, which means that while it can be very helpful to help you fall asleep, if you use them routinely for a period of time, we know that you're not going to be able to fall asleep if you stop using them, because you'll develop some rebound insomnia. We've also recognized that regular use of antihistamines for in patients over a certain age can lead to problems with memory issues. We know that regular use of antihistamines might worsen things like constipation, which many patients with Parkinson's disease already have anyway. And so we don't suggest that for regular use.
Okay.
Can I ask a question?
Yeah, go ahead.
I'm 87 years old, and I developed Parkinson's 4 years ago. I didn't have any problem sleeping. It's just the last year or so I really had problems trying to fall asleep, meaning I would try to fall asleep at 11:30, and by 3 o'clock at night I was still awake. I'm now, I think this last month, we solved that problem, but I think I have another one. I'm taking my regular dose of the levodopa and melatonin, 10 milligrams, and it's working. I'm getting between 7 to 9 hours of sleep, sometimes too much. Today I got 10 hours. I'm checking it on my Apple 5 software, and it's pretty accurate. But my problem now is when I get up, I feel dizzy. Is it the medication carrying over, or is it, I didn't check my blood pressure.
So with dizziness on waking, we always worry about a drop in blood pressure, especially if you've been, in bed for 9 or 10 hours. So the risk of having a drop in blood pressure is going to be higher. And so you're going to want to really begin to monitor that.
Right. The medication that the doctor prescribed is Miratazapine.
I would talk to your primary doctor about that, sir. I'm not able to comment on your specific situation on this venue.
It's working like a dream. I'm getting 7 to 9 hours sleep, and I go to sleep within 5 minutes.
Well, I appreciate that, but again, with your certain symptoms, you're going to want to talk to your primary doctor.
Okay.
Okay. Linda, I see that you have your hand raised. Does Linda have a question?
I did. I actually put it on the chat, but while you have me on the speaker, I'll go ahead and say it. I had REM sleep disorder several years before I was diagnosed with Parkinson's. Is that normal?
It's very common, certainly.
Okay, and if you have this sleep disorder, I mean, I have thrown myself out. I have hurt myself quite badly. I now have all my furniture with padding on it and rails on my bed, and I do take 4 melatonin, 12 milligrams every night before I go to sleep, which has helped me somewhat. But if you have REM sleep disorder, are you more likely to develop Lewy body dementia?
We can't make that as a prediction. Now, we do know that patients with REM, sleep behavior disturbance, seem to, or people with Lewy body dementia or other Parkinsonisms seem to be more apt to have REM sleep behavior disorder, but we can't use that presence of REM sleep behavior disorder as a predictive quality. We can't say you have REM sleep behavior disorder, therefore you are more at risk of X or Y. That's not possible.
Okay, thank you. And you can disregard my on the chat then.
Okay, thank you. Another question is, I wake up during the night feeling too hot. If I get up to use the restroom, then I feel too cold the rest of the evening. Is this typical of Parkinson's?
It's actually typical with being older. It may be typical of hormones. It may be typical of the bed covers that you have. So there's a number of different factors. I don't think we can blame it solely on Parkinson's disease.
Okay.
So
can oregano, pine bark extract, and rosemary, I think this is, or rosmarin, be combined safely with carbidopa levodopa?
how about that's one that we explore and maybe answer in the
Yeah,
messenger?
we'll answer later. Okay. I think that's it. I think you've addressed all the questions.
I have one more.
Okay, we'll take one more question. And then if you have other questions after we sign off, please email them to me, and then I will send them to Dr. Taylor, and we will address these questions in the next messenger newsletter, which will be coming out in November.
Okay.
Okay, go ahead.
My question is, has any of the marijuana, the oil,
You there?
We lost
help
you.
people with Parkinson's?
I think your question was, you cut out, but I think your question was, have any of the marijuana products been shown to be beneficial for patients with Parkinson's disease? For all of the studies that have been done in a controlled trial, they have not been shown to help the motor symptoms of Parkinson's disease. They have been shown to help mood issues such as anxiety. They have been shown to perhaps help sleep issues. That would be something that I would recommend or encourage you to speak to your primary care physician about, or your primary neurologist.
Okay, well, thank you, Dr. Taylor. Thank you all for joining us this evening. I think this was really valuable information. Dr. Taylor, are you going to share your slides with me, or?
Certainly, I'm happy to do so.
Are you okay if I share them with others if they ask for them?
Sure.
Okay. If you are interested in having Dr. Taylor's slides, please send me an email and I'd be happy to share them with you. Also, we did record this program this evening. We store all of our education programs on our YouTube channel. If you go to our website, parkinsonsmi.org, you'll see the YouTube icon at the top of the page. Click on that, and every education program that we've done for the last 4 years is recorded, and they are posted on that website. One really quick commercial. Dr. Taylor mentioned the importance of daily exercise will help you sleep better at night. Among other things, exercise is fabulous. We offer power moves, which is Parkinson Wellness Recovery, and yoga 6 days a week at 10 a.m., Monday through Saturday. We do it via Zoom. If you go to our website, click on the exercise icon, and the link is right there. These classes are free of charge. They are taught by physical therapists who specialize in neurological disorders, Monday through Saturday, 10 a.m. Okay? All
So,
right,
Linda,
folks. Yeah, go ahead.
Mary Sue, before you hang up, one last comment, and this is a plug on another one of your programs, and going back to caregivers and respite care. Keep in mind that the Michigan Parkinson's Foundation has a terrific respite care program. So if you are a caregiver and you wonder about maybe getting a little bit of a break, I know that Mary Sue has a great deal of information about that as well.
We do. We provide financial assistance for 168 hours per family per year, and you can use it however you want. A lot of people do use it, like maybe 3 nights a week, so that the caregiver can get a solid night's sleep to bring in overnight care. So if you are interested, please give us a call.
Thank you, Dr. Taylor. That was great.
You're very welcome. Thank you all for being here, and thank you for your attention.
All right. I'm going to sign off. Good night, Dr. Taylor. Everybody enjoy
Good night.
the rest of your evening. All right. Good night.
Thank you. Bye-bye.